Next speaker is Luca. Luca, are you here?
Yes. Hello.
Nice to see you back. Hello, Luca. It's a morning time for you. I hope it's not too early for you. We'll have the next talk from Dr. Luca RAGAZZONI. He's from the for Research and Training in Disaster Medicine, Humanitarian Aid, and Global Health at the University of Eastern Piedmont. Cremedim has been one of the pioneers and is one of the WHO collaborating centers since 2016, working on disaster and humanitarian issues. Luca is specialized in anesthesiology and intensive care, and he's led several different missions overseas. But more importantly, I think we would like to hear his experience responding frontline to the hit of COVID-19 pandemic to northern Italy early last year. So it's great to have Luca with us, and look forward to hearing from you, Luca.
So thank you very much, Kevin, for the kind invitation. It's a pleasure for me of being here and present our experience in Italy and abroad. So yes, of course, I would like to start my presentation starting from the first wave. So as we know, the COVID-19 pandemic is currently treating numerous health systems around the world, requiring an extraordinary international response. And this response includes effective education and training of healthcare workers to attain several operational level public health skills. And for example, in Italy, and not only in Italy, these skills are beyond the experience and knowledge base of most practitioners, not familiar with public health emergencies arising from infectious disease outbreak. As Kevin said, so Italy has been one of the most affected countries, especially during the first wave, but unfortunately also the second wave. And many healthcare workers have been working outside of their field of expertise, and the risk of secondary infection is still high here. So in February 2020, the implementation of just-in-time training intervention focused on population-based medicine and management skill was of paramount importance to equip healthcare workers with basic competencies to proficiently and safely work in any hospital and pre-hospital service during the pandemic. And as you know, just-in-time training is a well-established concept among disaster and humanitarian responders, as intended to rapidly address disaster-specific informations, tasks, skill, and knowledge just before the deployment to a disaster-stricken area to prepare providers for the deployment experience and also to maximize the effectiveness of the disaster response. So we have implemented this concept in the tertiary referral hospital, so the Novara University Hospital, which is the second largest third-level referral hospital of the Piedmont region, one of the most affected regions in the northwest Italy. So back then, while COVID-19 was rapidly spreading in the region, the activation of the hospital contingency plan for a massive influx of patients progressively established the transformation of hospital wards into a cohort intensive and non-intensive care units for COVID-19 positive patients. And at the peak of the admission, the emergency department and the ICU expanded their operational staff and structure to surge capacity. So we as a Cremedim, we supported and facilitated this transformation with principle and guidelines. and more than 200 COVID-19 beds were made available, and more than 300 healthcare workers were asked to change roles and tasks to equip these newly opened hospital units. So in this scenario, we recognize that COVID-19 just-in-time training was essential for the entire hospital staff to meet the needs of rapidly attaining competencies that were beyond the experience of most of them. And furthermore, we strongly believe that the unexpected magnitude of the crisis generated by the pandemic required not only the attainment of infection prevention and control and public health skills that are the core of population-based management, but also the awareness of disaster medicine principles, such as surge capacity and scarce resource allocation, triage and ethical dilemmas of rationing medical care. Therefore, we designed the COVID-19 just-in-time training to provide the entire hospital staff with a common background, competencies, and proper attitude needed to proficiently and safely work inside the hospital, understand the working principle and the standard operating procedure in place at the hospital, and accurately apply and safely remove the personal protective equipment. And as I just said, understand the basic principle of disaster medicine and public health emergencies applied to COVID-19. So we have published this experience back in April in Academic Medicine, one of the most renowned scientific journal that publish education and training in medicine in general. And these are the curriculum framework that we designed. And so the learning objective was to practically improve the public health management competence and awareness, and to improve attitudinal performance rather than delivering the mere knowledge and about COVID. And this experience was run every afternoon for 3 weeks in presence in the main hall of the hospital, maintaining social distancing. So the decision to deliver face-to-face training, okay, keeping the distance, keeping the safety and security, was very important to address and to equip the healthcare workers with these principles. And so on April, on today, after 14 months since the beginning of the outbreak in Italy, more than 50,000 Italian healthcare workers contracted COVID-19. These numbers reinforce once again how important is the implementation of training to address competencies that are beyond the experience of most of our colleagues. So in our hospital, for example, the risk, the healthcare workers that contracted COVID were very, very low. And the lessons learned from this experience is that our idea to address disaster medicine and population-based medicine concept was crucial, taking into consideration that the rapid insurgence of the spread of COVID-19 pushed to the limit the hospital contingency plan, generating a crisis management condition that collapses all major public health protection that society at the time depend on. And then that was the first experience for most of the healthcare workers, and was important to equip them with these basic principles. And because also, unfortunately, we are still struggling to add mandatory course in all university courses in Italy for doctors and nurses. Then this experience from a tertiary referral hospital was also implemented during the second wave when we established and developed an urban field hospital. So we are still in Piedmont. Now we were in November, so months after the first wave. So we are at the beginning of the second wave in Italy. And similarly to what was happening in other countries, Italy experienced an overboarding or its health system again in November. And public authorities and emergency medical service were struggling to find strategy to ease the strain of the health system. Therefore, we decided to open a field hospital in the middle of the main city in Piedmont, and Crimedim was appointed to develop guidelines and training. So this was a huge urban hospital for 450 beds, 8,000 square meters, and we were able to implement and open the field hospital in only 11 days. And Crimedim created guidelines for a model of care between hospital and community. And this was an idea for a step-down hospital, so patient recovering from severe COVID-19 and not ready for discharge, was exactly to obtain the space to maintain patient before discharging. So it was important for reverse triage in the hospital to improve surge capacity in the hospital and take safely the patient in this field hospital. And moreover, we developed training because most of the healthcare workers who worked in the field hospital have never experienced working in such conditions. So we facilitate the transfer of experience to make them aware and trained enough to work in a field hospital. So, for example, we try to implement guidance and soft skills for them. And one of the most important part was to run simulation to expose them to different scenarios that could happen in that field hospital. And for example, how the workflow of patients were created, triage, how to treat patients in the tents. Again, because most of the healthcare workers that worked in that field hospital, they've never experienced humanitarian work, working in such difficult conditions. And our training, just-in-time training, was of paramount importance to equip them with the attitude and basic skills. So the lessons learned here were that conceiving a model for low-intensity care for COVID-19 in an urban setting was important to reduce the burden of the hospital. And also was one of lessons learned is that an academic institution with important experience in disaster and humanitarian settings were so important to facilitate and to support governmental organization, public health institution here in Italy to improve the effectiveness of the response. And of course, simulation in this case was a key for them to attain and equip them in a rapidly. The last experience that I would like to show is also the remote virtual reality training that we have developed for different NGOs. So in our previous experience during the response of the Ebola outbreak in West Africa, we applied an innovative just-in-time training methodology using virtual reality simulation. We demonstrated that virtual reality simulation is effective to increase staff safety before taking on the risk of working within an Ebola treatment center. And we have published this concept in a scientific journal. Unfortunately, the rapid insurgence and spread of COVID-19 implied the urgency of to train healthcare workers everywhere in the world. So therefore, we implemented this COVID-19 community center layout together with UK Med, an NGO in England. And basically, we create a virtual reality environment to expose healthcare workers in understanding the working principle in a COVID-19 community treatment center. Because we knew that at that time also currently most of the country are struggling in treating patients in hospital, and one of the objective is to create the new community center hospital, also according to the WHO guidelines. And this, as you can see, the virtual reality is effective to expose participants in understanding how to work in such context. And also, as you can see from this second video, the first one was the triage area, and this one is the treatment area. Again, remotely, you can, of course, expose participants and healthcare workers to this scenario to clarify working principle and safety security measure within a COVID-19 treatment center when these participants are not experienced enough or never experienced this before. So why virtual reality? Because simulate highly specialized real-world environment. Training can be done remotely, ensuring access to a high number of staff. So you can deliver safe training for high-risk scenario. You can also increase knowledge retention because the participant can continue watching and trying to walk in several times. So you can reduce the cost and the travel, which is a key today for the current situation. And virtual and hybrid training provide a realistic virtual exposure essential to learn infection prevention and control measure. What does it mean by hybrid training? So you can add this virtual reality component in a face-to-face training. So thank you very much again, and I'm here to reply to any question.
Thank you, Luca, for your wonderful sharing. There's a lot that Primadim and yourself has done in sharing the just-in-time training, your training curriculum, that all published, and that's great to see. And also your virtual hospital, which is very impressive. Just before we go into questions, maybe we can have our last speaker, and then we can have a roundtable, if that's okay with you, Luca.